Here we have the systemic vascular resistance. A systemic vascular resistance equal to blood pressure divided by cardiac output. Here we see systemic vascular resistance decreased by 30%, and also we see blood pressure also decreased. But here we have the cardiac output is increasing, reaching nadir of the systemic vascular resistance by 20 weeks. This enhances uteroplacental transfusion. So the low systemic vascular resistance, or let's say systemic vascular resistance increasing by 30% enhances uteroplacental transfusion. And here we have the cardiac output. Cardiac output increasing by 50%, which is equal to high heart rate and high stroke volume. Major increase by 20 weeks, both increase in pregnancy. Heart rate is increasing by 20 beats per minute by third trimester. What do you mean here by saying third trimester? We mean from 26 to 40 week gestation. And here we have the stroke volume, which is increasing by 30% by the end of the first trimester. What do we mean here by saying first trimester? We mean from conception till 13-week gestation. Here we see that the cardiac output depends on the maternal position. How? We have the cardiac output, so how we get the lowest and highest value of cardiac output. Here we have the cardiac output. We have the lowest and highest, as we said. The lowest cardiac output, we get it in the supine position because of the inferior vena cava compression, resulting in decreased cardiac return. So we have less oxygen arrives to the brain. And here we have the cardiac output is the highest in left lateral position, and that will increase the oxygen that arrives to the brain. And we have the cardiac output increases progressively through the 3 stages of labor. So the body needs more oxygen and more blood flow, more blood flow and more oxygen during pregnancy. That's why it increases progressively through the 3 stages of labor. And here we have the murmurs, we have the systolic ejection murmurs, we have the diastolic murmurs. Here we have the systolic murmurs along the left sternal border is normal in pregnancy owing to the high cardiac output passing through the aortic and pulmonary valves. So here we see that the systolic ejection murmurs related to the high cardiac output through the aortic and pulmonary valves. And here we have the diastolic murmurs are never normal. So if I want to ask you which one is abnormal, we see according to the cardiac output, we see that high cardiac output in systolic and low cardiac output in diastolic. So diastolic is never normal in pregnancy and must be investigated. And here we have the hematologic changes in pregnancy. We have high red blood cell, we have high white blood cell that may reach 16,000 cell per millimeter cube. We have high erythrocyte sedimentation rate, but here we have the platelet count is unchanged, and the coagulation factor are increasing and may cause hypercoagulable state. We have here the red blood cells increased by 30% in pregnancy, oxygen carrying capacity increased, plasma volume increased by 50%. Unfortunately, the hemoglobin and hematocrit decreased by 15%, and the nadir of hemoglobin reached 28-30-week gestation. This is physiological delusional effect, but not pathological, or it's not a manifestation of anemia. It is a physiological delusional effect. And here we have the white blood cell count increases progressively during pregnancy. Mean value 16,000 per millimeter mercury in third trimester. What do we mean here by third trimester? We mean from 26 till 40-week gestation. And here we have the note about the trimesters. First trimester we mean from conception till 13-week gestation. Here we have the second trimester from 13 to 26, third from 26 till 40, week gestation. And here we have the erythrocyte segmentation rate increases in pregnancy because of the increase of the gamma globulin. So here we have the high ESR equal to high gamma globulin. And here we have the coagulation factor. We have 5, 7, 8, 9, 10, and Willebrand factor increase progressively in pregnancy and may cause hypercoagulable state.